degeneration, deterioration, decay of soft tissue that cushions the knee, aka the articular cartilage. It is caused by repetitive stress on the knee that leads to breakdown of the articular cartilage. It can also be caused by prior surgeries, trauma, infection. It is the leading and number one cause of musculoskeletal debility, aka physical weakness, in the world. Up to 28% of Americans over age 45 had this condition. Stay tuned to learn more about this debilitating condition.
Welcome to Region Med 101 podcast with Dr. Yu. Learn about all things medicine, health, and wellness. We hope you enjoy listening. Please show your support by subscribing and follow our podcast.
Knee osteoarthritis, or knee OA. For the remainder of this podcast, knee osteoarthritis will be referred to as knee OA. Knee OA, it leads the world in physical musculoskeletal debility. 28% of Americans over age 45 suffer from some degree of knee OA. The main cause is due to wear and tear from repetitive stress on the knee. The risk factors, otherwise known as things that increase the chances of developing the disease, include older age, being female sex, although plenty of men suffer it too, obesity, osteoporosis, some ethnicities, genetic causes, diet, mainly poor diet, muscle weakness, altered walking mechanics, knee joint laxity, otherwise known as looseness, or deformity, otherwise known as misshapen anatomy. Work factors, certain competitive sports, especially high strain or knee sports like running, skiing, basketball, soccer, or hockey. Also, previous trauma such as old knee injuries or prior surgeries. How does knee OA occur? The knee joint between the two bones, the thigh bone, otherwise known as the femur, and the shin bone, otherwise known as the tibia, has a small cartilage, meniscus, soft tissue, and ligaments inside the knee. Knee OA is due to loss of cartilage matrix and chondrocyte injury. Under the microscope, there is a focal, macroscopic, chondral, and subchondral injury. These are known as microscopic injuries. Cartilage swelling can also occur. Cartilage breakdown occurs with repetitive injury, and this cartilage loses structural integrity. It results in synovial inflammation, immune cell activity increases, leading to further breakdown of soft tissue. Sometimes the injury may be so bad that the cartilage is destroyed and the soft cushion is no longer there, meaning there is now bone-on-bone wear and tear. How do patients typically present? Knee OA starts off insidiously, gradually, in subtle ways. Symptoms start to worsen over time. Pain comes in spurts. Patients usually note pain with walking, transfers, going up and down stairs. Sometimes there is locking of the knee, stiffness, and this is due to formation of what's called loose bodies. Loose bodies are from degenerative meniscal tears and osteophyte formations. They're like little bony islands that form inside the knee joint. Pain can increase in severity and leads to hindrance of daily activities and reduced quality of life. Knee OA has been linked to deformities of the knee joint, altered walking mechanics, and can lead to what's called pes anserine and or trochanteric bursitis. Knee OA can lead to altered gait patterns and leads to shifting weight to the other leg, which then leads to OA of the other side. Knee OA that leads to reduced activities then leads to health effects such as weight gain and reduced cardiovascular health. Physicians should know that there is an American College of Rheumatology criteria that is 95% sensitive to diagnosing knee OA. These include 1. Knee pain, 2. At least 3 of the following: greater than 50 years old, morning stiffness for less than 30 minutes, crepitus on active range of motion of knee, bony tenderness near knee joint line, bony enlargement around knee joint, and no palpable warmth. Physicians should assess for joint hypertrophy, varus and valgus deformity, effusion, and skin changes. Palpation to note tenderness at joint lines, such as the medial joint line or the patellofemoral articulation. An effusion may be palpable at the suprapatellar bursa and associated ballottement of the patella. Range of motion may be limited early in course of disease, with limitations in extension typically later in stages. Neurological testings to rule out nerve disorders should also be done. Special tests include instability testing using valgus and varus testing. Lab tests should be considered if RA or other systemic disorders are of concern. ESR, rheumatoid factor, and synovial fluid aspiration can be tested if applicable. Imaging. This is important and should be done while weight bearing. AP, lateral, notch, and merchant views are recommended. X-rays can show joint space narrowing, subchondral bony sclerosis, osteophytes, cysts, and loose bodies, as well as varus and valgus alignment and osteopenia. Kellgren-Lawrence radiographic grading for OA can also be used. In this grading scale, grade 0 is no radiographic findings of OA. Grade 1, minute osteophytes of doubtful clinical significance. Grade 2, definite osteophytes with unimpaired joint space. Grade 3, definite osteophytes with moderate joint space narrowing. Grade 4, definite osteophytes with severe joint space narrowing and subchondral sclerosis. When radiographic evidence of osteophytes is added to the American College of Rheumatology's classic clinical criteria, the criteria has a sensitivity of 91% and a specificity of 86% for diagnosis of knee OA. MRI may be considered, usually after conservative treatment has failed, pain worsens, or if evaluation of the knee has concern for stability and/or severe tears of ligaments or meniscus. Ultrasound imaging can be used to assess for knee OA features and even evaluate for meniscal or even ligamental tear. Treatment options. The American College of Rheumatology, as well as the American Academy of Orthopedic Surgeons and the Osteoarthritis Research Society International, have published guidelines for the treatment of knee OA. The recommendations include low-impact land-based exercises, strength training, neuromuscular education, self-management, education, weight loss in obese patients, aquatic exercises for those that are unable to work out in ground-level surfaces. Medication. Medications may be trialed include Tylenol, oral NSAIDs, topical NSAIDs, sometimes even tramadol, and even intra-articular corticosteroids may be used. Some physicians may also offer intra-articular hyaluronic acid injections or PRP injections. There are some published reports that have shown good results. Some studies have even shown PRP have more effect at reducing pain when compared to placebo and hyaluronic acid injections. Consider these when speaking to your physician. Please look out for future episodes on RegenMed 101 regarding PRP injection. If conservative and interventional treatment have failed, surgery should be considered and discussed with your doctor. Surgeries would include joint arthroplasty, arthroscopy, debridement, as well as other options. The goal for knee OA patients include staying active, home exercise that work on strengthening the quads, hamstring, calf, and core strengthening, improving knee pain. Low-impact activities are best. Aquatic exercise is helpful and can reduce significant pain if walking on solid surfaces are difficult or if weight is an issue. Access to resistance exercise equipment and safe walking routes or treadmills can help patients remain strong and active. Losing weight, although easier said than done, and a careful review of what you eat for breakfast, lunch, and dinner, as well as the snacks and beverages you consume every day, can add up over the weeks, months, and year. Decreasing portion size, drinking less, or even avoiding sugary beverages, and limiting and avoiding alcohol, as well as stopping all smoking, are all going to be the first step in improving knee OA. Knowledge is power, and it is the first step in knowing your condition, disease, or injury.
If you enjoyed listening to our podcast, please visit our Instagram, Twitter, and Facebook. For more detailed information, please visit our website at RegenMed101.com.
This podcast is made for the general education to the public and is not intended to substitute for or provide medical advice. All information, content, and material from Dr. Yu and his guests on RegenMed 101 is for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician. Please see podcast and page content for full disclaimer. If you have a medical emergency, call your doctor or 911 immediately.